I'm Mike Breyer. I'm a professor in the Department of Nephrology, and I'm actually in charge of aligning up the candidates to give medical grant rounds for the division. And it is my pleasure today to introduce one of our younger faculty, Dawn Castor, to present the work that she's been doing on lupus nephritis and an update. Dawn is a graduate of the nephrology division at the University of Louisville, and at that time we thought that she might be interesting to keep around, and so we invited her to the faculty. She competed with the NIH and received a training grant for research in the area of glomerulonephritis, and she runs a GN clinic that is widely respected within the community and regionally, where she receives individuals seeking out her expertise. She is also internationally recognized in this area and participates in the KDIGO guidelines, where they determine clinical practice guidelines in the area of glomerulonephritis, and we are happy to have her present today an update on the diagnosis and treatment of lupus nephritis and introduce some of the new drugs that are available in this area. So without further ado, Dawn, lead us on.
Great. Thank you so much, Dr. Breyer, for that introduction, and hope everyone can hear me wherever you may be. It's a little difficult not having an audience, but I'm very thankful you guys are out there and listening early this morning to go over a topic that's become near and dear to my heart, and this is lupus nephritis. It's an area that if you had asked me when I was actually a trainee, for all those trainees out there, back when I was a medicine resident, I had no idea that I would spend a career studying this. But thanks to some experiences early in my nephrology fellowship, I was introduced to this perplexing disease. So the talk today is primarily focused on the clinical components of lupus nephritis. But I'm happy to give a talk in the future regarding my translational research as well. So the title of this talk is Taming the Wolf, an update on the diagnosis and treatment of lupus nephritis. And I do have some disclosures. The following companies I've consulted for are Aurinia, Calliditas, GSK, Retrophin, which is now Travere, and I'm also on the Speakers Bureau for GSK and Aurinia. And I have funding currently through the NIH and a Career Development Award. So the primary learning objectives are to get you excited about lupus, but also to review the current classification system of lupus nephritis, summarize the current guidelines for diagnosis and standard of care treatment of lupus nephritis, and review recent clinical trials in the treatment of lupus nephritis. 2020 had been a very challenging year in a lot of ways, but it was also a year where we had 2 positive clinical trials in lupus nephritis come out, and one, the first actual FDA-approved treatment for lupus nephritis specifically, was approved in December of 2020, and the second one was approved in January of 2021. So the last 2 years have really marked a lot of advancement in the treatment of this disease. So I thought it's important to go over that today. So the history of systemic lupus erythematosus goes back to the Middle Ages. And if you're wondering where we get that term lupus, which is Latin for wolf, it was first used to describe the skin lesions associated with lupus by a 13th century Italian physician by the name of Rogerius. And he coined that term just based on what he saw. Move forward a few hundred years, and we've all probably heard of Moritz Kaposi, who identified the lesions of Kaposi sarcoma. But he also, he was a dermatologist who observed that lupus erythematosus went beyond the skin. And this is a quote by him, that experience has shown that lupus erythematosus may be attended altogether by more severe pathologic changes and even more dangerous constitutional symptoms, and may be intimately associated with the process in question, and that death may result from the conditions which must be considered to arise from the local malady. So he really, identified that this was a systemic disease and often deadly disease, especially in patients with kidney involvement prior to the 1950s, that resulted in early death. And of course, we all know William Osler, and he published case reports on a visceral erythema group of patients with skin manifestations and systemic disease, including glomerulonephritis. So this whole recognition of lupus as beyond the skin and as a systemic disease started kind of at the turn of that century. And then we have the modern era, where there's the identification of serologic markers for systemic lupus and the first initial treatment with corticosteroids. So in 1948, the LE cell was discovered, and then shortly after that, I might be mispronouncing that developed the first blood test to detect anti-nuclear antibodies. And then 1948, what the discovery of cortisone really was a game changer, and so much so that in 1950, the Nobel Prize in Medicine went to Hensch, Kendall, and Reichsten for the discovery of cortisone. And Hensch was a rheumatologist at the Mayo Clinic, and he was the first to describe the use of corticosteroids to treat rheumatologic conditions. So really, prior to the 1950s, systemic lupus was extremely deadly, and there were no treatment options for patients. So what is the pathogenesis of systemic lupus? It's very complicated. So there are genetic, environmental, immunoregulatory, and hormonal, as well as epigenetic factors, which essentially lead to the loss of self-tolerance, the development of immune complexes, autoantibodies, and then T-cell activation, formation, and cytokine release. And of course, those autoantibodies can attack different organ systems, and the inflammatory response, of course, can attack different organ systems. But for the focus of the talk today, I will be focused on my favorite organ system, which are the kidneys. So lupus nephritis occurs when immune complexes deposit in the mesangium and subendothelial and subepithelial space of the glomeruli. And the pattern of glomerular injury is related to the site of immune complex deposition and local inflammation and cytokine release mediated by a combination of factors, genetic and environmental, contribute to the severity of glomerular injury. So, essentially, just a bad mix of combination of genetic risk as well as potential environmental influence leads to this loss of immune tolerance, and eventually, as this goes on, you get organ involvement. And why some people develop nephritis and others do not is not fully clear, but nephritis does occur in approximately 50% of patients with SLE. Certain groups are much more likely to get nephritis as opposed to others. And unfortunately, despite having some treatment options for patients, up to 30% of patients with lupus nephritis will eventually progress to end-stage renal disease. Lupus disproportionately affects women and minority populations. So this is a disease where 9 out of 10 patients with SLE are women, and patients with African and Hispanic ancestry are much more likely to be diagnosed with SLE and lupus nephritis. And they're also more likely to present with lupus nephritis at initial diagnosis. And then patients with African and Hispanic ancestry are more likely to develop end-stage renal disease from lupus nephritis. And another thing to note is this is a disease primarily of young women of childbearing years. So they present as teenagers in their 20s and in their 30s. So this is a disease that affects people at the prime of their life that really is devastating, and we really need better treatment options for patients. So I'll admit these are not my patients. So and any medical information I have on these celebrities comes from E! News and other gossip columns. But here we have Nick Cannon, Tony Braxton, and Selena Gomez, who actually is probably the most famous of our lupus nephritis patients. And part of the reason I'm showing them here is because I want to emphasize that lupus patients often don't look that sick. They're younger, and they can look deceivingly healthy. And we know Selena Gomez, or at least I know, maybe I'm watching too much gossip news, but that she underwent a kidney transplant a couple of years ago because she developed renal failure from her lupus nephritis. And I imagine that she probably had pretty good access to care. So this really highlights, unmet needs and better treatment options for lupus nephritis. So I'm going to go to actual real cases of mine. So I can't show their pictures though. So this case actually I'm showing, and I know some of the faculty in nephrology are familiar with this patient, but I'm showing because this is the case that really changed the trajectory of my career. I was I think 2 months into my fellowship in nephrology when I encountered this patient. So I'll start with the beginning of her course. So at 16, this patient presented with fatigue, shortness of air, and a rash. Her creatinine at the time was 0.6. Urinalysis showed 100 milligrams of protein and RBCs, and urine protein to creatinine ratio was 1.2 grams per gram. A serologic workup revealed an ANA titer of 1 to 320, positive anti-double-stranded DNA, and low complement levels. And then her kidney biopsy showed class 4 and class 5 lupus nephritis with moderate to severe activity and no chronicity. And 10% of the glomeruli were found to have cellular crescents. And at this point, she's initiated on a pretty heavy-duty immunosuppressive regimen with IV cyclophosphamide and corticosteroids. She completed a 6-month course and then was placed on maintenance therapy with prednisone and mycophenolate mofetil. Following this diagnosis, she continues to have frequent lupus flares with multiple admissions. Her creatinine increases to the 1.2 to 1.3 range, which from 0.6 is a big change, but I think a lot of clinicians outside of nephrology, don't look carefully enough at that. In a young woman, 1.2 to 1.3 is definitely too high of a creatinine level. And her creatinine was relatively stable for a year, and then she becomes pregnant and is taken off of MMF. 3 months later, she's admitted with a miscarriage and acute kidney injury. And at this point, she's an adult patient that we saw in consult in the inpatient service. So I saw her at this point, and we repeated a kidney biopsy. And at this point, her biopsy showed class 4 and class 5 lupus nephritis, but this time 90% crescentic lesions, which these are these highly inflammatory lesions in the kidney. She's treated again with another course of IV cyclophosphamide and high-dose steroids. However, her kidney function rapidly declines and she initiates dialysis. So at 18 years old, she has end-stage kidney disease. The second case I'm showing, because this case was a case I saw, also in fellowship, but it was frustrating for another reason. This patient seemingly had relatively good disease control and still had a poor outcome. So this is a 36-year-old African-American female who presented with edema and fatigue. Initially was found to be nephrotic with 7.5 grams of protein on a ratio, and her creatinine was 1. Serologic testing showed that she had a positive ANA and anti-double-stranded DNA, but normal complement levels. Outside the fatigue, didn't really have a lot of systemic symptoms. And her kidney biopsy revealed membranous nephropathy with IgG, C1q, and C3 staining on immunofluorescence, and EM, which showed both mesangial and subepithelial deposits, which is consistent with the secondary membranous, which we thought was consistent with class 5 lupus nephritis. At that point, she was placed on prednisone and cyclosporin and achieved a partial remission, with her proteinuria going from 7.5 grams to 1.5 grams at 1 year. However, 5 years after the initial diagnosis, her proteinuria returns. At this point, she's placed on a slightly different immunosuppressive regimen with mycophenolate mofetil and prednisone, and her creatinine increases to 1.6 despite the addition of immunosuppressive therapy. So she underwent another biopsy. And her kidney biopsy at this point showed advanced glomerular sclerosis and significant interstitial fibrosis without evidence of disease activity. At this point, she's taken off of immunosuppression, and she has progressive chronic kidney disease. And 10 years after her original diagnosis, she initiated dialysis. So I call this a tale of two cases. They highlight the heterogeneity in this disease in presentation and disease course, and likely an underlying pathophysiology. In case 1, you have massive inflammation leading to end organ damage and eventual fibrosis. And in case 2, you have kind of this more indolent process of damage, which leads to fibrosis. In both of these cases, you have the same unwanted outcome, long-term outcome of end-stage kidney disease, which as a kidney doctor taking care of these patients, my number one goal is to preserve their kidney function as long as possible. So I call case 1 the wolf in wolf's clothing. So these cases are pretty obvious. We know when patients have really bad lupus and have bad disease, and it hits us pretty hard. But in these other cases where, the proteinuria persists, we have to understand that this is our wolf in sheep's clothing. It might take a little longer for them to get to end-stage kidney disease, but they still have ongoing damage if they don't get to that complete remission point. So we really, again, have a lot of room for improvement in this disease. So how do we monitor patients and diagnose lupus nephritis? So of course, all patients with underlying systemic lupus that already have diagnosis are at risk. So they should have blood pressure monitoring, kidney function labs, urinalysis with microscopy, and a urine protein creatinine ratio at least every 6 months. And the old ACR 2012 guidelines recommend that every 6 months, but the newest guidelines in lupus nephritis were released by the EULAR, ERA-EDTA, that's a mouthful. It's the European Rheumatologic and Renal Societies in 2019, and they actually recommend surveillance every 3 months if patients are high risk. And kidney biopsy should be considered anywhere there's evidence of kidney involvement. So anytime you have proteinuria greater than or equal to 500 milligrams a day, this is a pretty low point for biopsying a patient. But if you have someone at risk that has known lupus, they can actually have pretty significant disease at this proteinuria level. Glomerular hematuria and cellular casts present, also an indication, and any unexplained decrease in GFR. So what does the biopsy show us? So currently we are in the ISN RPS 2003 classification system, and there has been a recent update proposed, which I'll go over as well, but it has not been widely adopted yet. So most of the pathology reports that you read from a patient that's been biopsied that has lupus nephritis are going to be guided by this 2003 classification system. So Class 1 and Class 2 are things I never see because most of these patients don't get biopsied because they don't have significant evidence of renal disease. And you can see here that for this patient with Class 1, it's called minimal mesangial lupus. It's represented by some scant immune complex formation in the mesangium. But really the capillary loops are open and there's no immune deposits there. For Class 2, it's just more mesangial proliferation. Again, something we rarely see on biopsy. So these are the classes you need to be familiar with. These are the ones that are really clinically relevant and require disease-specific treatment. So Class 3, focal proliferative lupus nephritis, is really characterized by the presence of subendothelial deposits, and I think this diagram actually shows them a little bit better. Most of these patients also have mesangial deposits. And the main thing that really distinguishes Class 3 from Class 4 in this classification system is really the number of glomeruli involved. So if you have less than 50% of the glomeruli that were biopsied involved, then you're considered Class 3. If you have greater than 50%, you're considered Class 4. Now they do go on in Class 4 to kind of talk about segmental versus global involvement of the glomeruli. So in Class 3, you're more likely to have just part of the glomeruli affected, so these more segmental lesions, although that's not universal. And in Class 4, you can have the immune deposits go all along the capillary wall involving the whole glomerulus. So, so Class 4, the main thing to remember is it involves more than 50% of the glomeruli in the biopsy. And then we have this other lesion called Class 5, which is membranous. And this is characterized by subepithelial deposits. So the epithelial cell of the glomerulus is the podocyte. And when you get subepithelial deposits, a lot of times you have the presentation of nephrotic syndrome because these podocytes are so important in the prevention of proteinuria. So when they get damaged, patients will have a higher grade of proteinuria. So for the other thing to keep in mind is you can have a Class 3 plus a Class 5 lesion or a Class 4 plus a Class 5 lesion. And often patients that have these mixed, what I call proliferative and membranous lesions, have really high levels of proteinuria and inflammation and can be much more resistant to treatment. So the other thing about the classification system is it includes this designation of A for active lesions and C for chronic lesions. And the patients I find most fall in this category of A/C if both active and chronic lesions are present. And then I had mentioned this earlier, Class 4 is subdivided in these segmental versus global lesions, depending on the pattern of injury in the glomeruli. There are some drawbacks to this classification system. So it does not involve vascular lesions or address the presence of, TMA. Most pathologists will, of course, mention it if it's there, but it doesn't put these in a category. It also does not address podocytopathy. So sometimes we just see foot process effacement on the biopsy, and this isn't clearly delineated. It also doesn't address tubular interstitial injury. And this designation of active chronic or active/chronic lesion does not adequately provide an activity index. So there's been a proposed revision to this classification system that was just published in 2018. This is a group of nephropathologists, a working group that proposed these changes to the current classification system, including some people that, if anyone here trained at Vanderbilt, You probably know Dr. Fogo. But essentially, this hasn't become widely adopted, but, of course, it's only 2 years old. So I would look out for this potentially coming into play in the future. And the main take-home point of this is they are putting in a new revised activity and chronicity index to kind of better delineate these active versus chronic lesions. And I think in the long term, if this is adopted, it might be helpful to better, I guess, define the activity in patients based on biopsy. Still not widespread yet. So I'm going to move on from the diagnosis and the biopsy findings to the treatment. So currently, most people are using the ACR and KDIGO 2012 guidelines, which of course are, 8, almost 9 years old now. So both of these systems are probably going to be revised in the coming years. So I know KDIGO had their draft guideline not published, but available for public view last summer. So expect to see those out sometime in 2021. ACR I'm not involved with, so I'm not familiar how soon they're planning on updating their guidelines. The most recently published guidelines are from Europe and are the EULAR, ERA, EDTA guidelines. And I'll try to point out where this last guidelines might differ a little bit from the EULAR guidelines. So induction therapy, also called initial therapy, really has not changed. And this is used for either class 3 or class 4, or if anyone has a combined class 3, 4, or 5+5 lesion. So really, for initial treatment, you have 2 options. You can go with mycophenolate mofetil or cyclophosphamide. There are different cyclophosphamide regimens. The Lupus regimen is becoming more standard, but the NIH regimen is still often used, and I'll go over those on the next slide. In both of these, patients receive glucocorticoids, pulse followed by a prednisone at a level of 0.5 to 1 milligram per kilogram per day, followed by a taper. Now, a big change in the 2019 EULAR guidelines are that they're really pushing a lower prednisone dosing system because of the toxicity associated with prednisone, and are recommending potentially 0.5 milligrams per kilogram per day as a starting point, as well as potential lower dose prednisone option. And I will say that the KDIGO new guidelines also address this kind of lower dose, not really low dose, but a lower dose prednisone regimen. So here's some of the, this is a comparison of the cyclophosphamide regimen. So the classic that was used since the late 70s was the NIH protocol, which is 0.5 to 1 gram per meter squared monthly for 6 months. A lot of people have replaced this with the Lupus regimen, which is cyclophosphamide 500 milligrams every 2 weeks for 3 months. And part of the advantage of that regimen is there's a lot less gonadal toxicity overall. It's a lower cyclophosphamide exposure. Oral cyclophosphamide, rarely used, but still mentioned here as an option. Of course, the cumulative dose with oral cyclophosphamide is much higher than either IV dosing. So maintenance therapy follows this initial therapy regimen. So I mentioned induction therapy lasting 3 to 6 months. And then patients get on a maintenance regimen. So when patients come to me, I try to prepare them that they're going to be seeing me a lot, and they're going to be seeing me for the long haul. Essentially, once you're a lupus nephritis patient, you're never not a lupus nephritis patient. So Maintenance therapy following that initial phase consists of either mycophenolate mofetil, plus or minus low-dose prednisone, or azathioprine plus or minus low-dose prednisone. And how long patients stay on maintenance therapy is controversial, but most guidelines recommend a minimum of 3 years, and only considering tapering if a patient is in complete remission and does not look like they have disease activity. So class 5, when it's by itself, so this is the membranous lupus nephritis, the treatment is a little different. So, and it differs, so the ACR and KDIGO were pretty similar for the proliferative forms, but they do differ a little bit in their recommendations for class 5. So both of these recommend only giving therapy if there's nephrotic proteinuria, so more than 3.5 grams a day. I will let you know that the new EULAR ERA EDTA guidelines actually have a caveat for this. They recommend that patients that are subnephrotic, so they have less than 3.5 grams a day, be treated aggressively with RAS blockade and non-immunosuppressive therapy. But if their proteinuria persists above 1 gram a day, they are recommending treatment of subnephrotic proteinuria. Now, I'm not sure, I don't think KDIGO is going to go down to 1 gram a day recommendation. The final report for the updated guidelines is not back, and I'm not sure what ACR is going to say about that. So this is an area of controversy that may come out and play with the different guidelines updating in the next year or two. So it will be interesting what ACR and KDIGO do say about subnephrotic proteinuria in class 5. So current guidelines that we are following recommend treatment of nephrotic proteinuria. So I just want to make that clear. And the ACR is recommending MMF and prednisone as a first-line therapy, followed by maintenance with MMF or azathioprine. KDIGO gives a few different options. So they recommend corticosteroids and cyclophosphamide, or a calcineurin inhibitor, or MMF, or azathioprine. So it's kind of a long list of potential options for class 5. And then what do we do for resistant disease? So American College of Rheumatology recommends switching after 6 months from one first-line therapy to the other first-line therapy. KDIGO, the only difference is they recommend switching after 3 months. And then consider the addition of rituximab or a CNI. And as I'm going through all these therapies, I want to just point out that all the therapies in these guidelines are actually technically off-label. So these are treatment guidelines, but none of these medications, MMF, cyclophosphamide, calcineurin inhibitors in general, or rituximab, have been FDA approved for the treatment of lupus nephritis. So what are the goals of treatment? So the goals of treatment by the prior 2012 guidelines were, response as determined by the provider. So it really was not clearly delineated what you called someone that was a non-responder or someone that had resistant disease. Was it their GFR falling? Was it their proteinuria not falling? What were the determining factors? And this is one thing that I really like from the new EULAR ERA EDTA guidelines, is that they really spell it out a little more clearly. So they recommend by 3 months that you see a 25% reduction in proteinuria, a normalization of GFR, and by 6 months, a 50% reduction in proteinuria. And then by 12 months, you really want to see that proteinuria go down to less than 0.5 grams to 0.7 grams in 24 hours. So why this change. Why target proteinuria? So the goal of treatment, as I've stated earlier, is to prevent end-stage kidney disease, to prevent chronic kidney disease, and of course we all want to prevent death. The reality is the best in long-term studies. So this is a 10-year follow-up of the Maintain trial. In long-term follow-up, they found that 12-month proteinuria of less than 0.5 grams a day had a 92% positive predictive value for good long-term outcome. And you can see here, this is from that paper, and at baseline, there was no significant difference in the 24-hour urine protein levels in these patients. So these are the patients that had a good outcome. These are the patients that had poor long-term outcome. By month 3, this early in the whole treatment process, we're already seeing a separation. Month 6, month 12. So patients who respond early and rapidly to treatment are much more likely to have good long-term outcome. This was another study, the Lupus Nephritis trial, long-term follow-up, so 7-year follow-up data on patients, and they found that the 12-month proteinuria level of less than 0.8 grams, so maybe we don't have to get to 0.5, but around 0.8 grams had an 88% positive predictive value for long-term outcome. Now the caveat here is both of these studies, the Maintain trial and the Lupus Nephritis trial, were in European populations. So, we hope that there's some generalizability, but they were different than the U.S. population as a whole. So how do we achieve these treatment targets? Well, I want to tell you, all those standard of care therapies I went over actually achieve a complete response rate less than 50% of the time. So less than half the time, and in some studies it's down to 20-30% of the time, are we actually achieving complete response with our current standard of care in lupus nephritis. Now I will repeat that because it's abysmal. Less than half the time in our current standard of care treatment for lupus nephritis are we achieving complete response rates. And not only that, these response rates come from clinical trials. So clinical trials have kind of the ideal patient setting. Patients have incentives to come in, they have pill counting. So this is when adherence is the highest. It's typically much better adherence than in the typical clinical setting. So if we're seeing response rates in clinical trials of less than 50%, what are we seeing in the actual clinical settings? Probably a lot worse. So how do we improve this? So over the last decade, there have been a number of trials looking at additional therapy to improve response rates in lupus nephritis. So this is a host of failed trials in lupus nephritis. So it had been pretty depressing. We had several, we were excited about new biologic therapies targeting different parts of the immune system. And here you see multiple phase 3, phase 2 studies that failed to meet their endpoint. But have we turned a corner? So obviously I wanted to give this talk because I told you that this year has been a really exciting year for lupus nephritis. The last 12 months have seen 2 positive phase 3 trials and 2 new medications become the first FDA-approved medications for the treatment of lupus nephritis. So I'm going to go over these studies in a little more detail because you're probably going to hear about these medications in the treatment of lupus nephritis. So the first is the belimumab phase 3 clinical trial, or the BLISS-LN study. And the second is the voclosporin phase 3 clinical trial, which is the Aurora study. And I will disclose we were a clinical site. It was a multinational, multi-site study. And I was the site PI here at University of Louisville for the Aurora trial. So First, I'd like to go over the belimumab trial. So belimumab is a human monoclonal antibody targeting BLyS or BAFF, which is a basically affects B cells. So it was approved for systemic lupus since 2011. So it's been actually a drug that is available and approved for the treatment of systemic lupus. Sorry, not lupus nephritis, but approved for SLE since 2011. And in the trials that led to the approval of use in SLE, patients with significant renal involvement were excluded. So they decided to study renal disease specifically, and they did this in the belimumab phase 3 clinical trial. It was a phase 3 randomized double-blind placebo-controlled trial, which used monthly belimumab IV versus placebo in combination with standard therapy over 2 years. And they had 448 patients, which is a lot for a lupus nephritis trial. What I emphasize here is they say standard therapy because in this study, patients could either be on urolupus cyclophosphamide regimen for induction, or they could be on mycophenolate mofetil. And if they were on mycophenolate mofetil for induction, they stayed on that for maintenance. And if they were on the urolupus cyclophosphamide, they went to azathioprine for maintenance. So it was in the background of standard therapy that was determined by the physician. And essentially, and this was, of course, in combination corticosteroids. So the inclusion criteria, patients had to have SLE, ACR criteria diagnosis, and a biopsy-proven class 3, class 4, or class 5 lesion. They could also have a class 3 plus 5 lesion or a class 4 plus 5 lesion. So these combined lesions were also included. And the UPCR had to be greater than or equal to 1 gram. Exclusion criteria were dialysis within 1 year, a GFR less than 30, or a B-cell targeted therapy within 1 year. And the way the trial was set up, belimumab was given at 10 milligrams per kilogram IV, day 1, day 15, and day 29, and then monthly, plus the standard of care therapy, as I described, or patients got standard of care plus a placebo. Their primary endpoint was this primary efficacy renal response, or PERR, which is another mouthful. And you'll find in clinical trials in lupus nephritis, endpoints vary, so it's really important to outline what they were. And they defined this endpoint as a UPCR of less than 0.7 grams per gram, so a little higher than what's considered a complete response, but close to the number which I had described earlier led to best long-term outcome. And eGFR greater than or equal to 60, or if it was less than that at baseline, not reduced by more than 20%. And then prednisone had to be down to 10, so it had to be down to 10 milligrams a day. And sorry, I did a typo there. And secondary endpoint was complete response, which is this UPCR of less than 0.5 grams per day or equivalent, and the eGFR of greater than or equal to 90 and not reduced by more than 10%. And then the prednisone had to be down to 10 milligrams a day after week 24. So this is their, and sorry if this, hopefully it's a little clearer on your screen, but this is the outcome. So this is their primary endpoint here, the PERR over time, and you see the belimumab group in blue and the placebo group in black, and you see around month or week 24 that these really start to separate, so around 6 months into treatment. And This was a 2-year study, which is remarkable in the clinical trial world. You see the separation occur and stay there through the duration of the study. So patients that were treated with belimumab on top of standard of care had a PERR of 43% versus 32% in the placebo arm, which was the active, control arm. They got standard of care. So 43% versus 32% was statistically significant, so they met their endpoint. And you can also see that as a secondary endpoint, this complete renal response, which the rates are much lower, but the patients in the belimumab group also did better than the placebo. And the probability of achieving this was higher in the belimumab group versus placebo as well. So positive outcomes, they met their endpoints. And importantly, the adverse events, because of course this is add-on therapy, you're adding immunosuppression on top of an immunosuppressive regimen. The adverse events were similar in both groups, so there were no major safety concerns, and belimumab was FDA approved for the treatment of lupus nephritis in adults in December of 2020. So we have another option. And now I'd like to move on to the next study, which is voclosporin, phase 3 clinical trial, which is the Aurora study. I think there's another study named Aurora in cardiac literature, so I'm sorry if we stole the acronym. This was a double-blind randomized controlled trial as well, center, multi-site, multinational study, including U.S. sites. And a total of 357 patients were enrolled. The inclusion criteria was fairly similar to the BLISS-LN trial. Everyone had to have a diagnosis of SLE, a kidney biopsy within 6 months, confirming the histologic diagnosis of lupus nephritis, and biopsy-proven lupus nephritis. Class 3, class 4, or 5, combined 3, 5, 4, 5. The proteinuria had to be a little higher for this study, so greater than 1.5 milligram per milligram, which is the same as saying greater than 1.5 gram per gram on the ratio. It's the equivalent of 1.5 grams per day of proteinuria. But if you were class 5 alone, you had to have more than 2 milligrams per milligram on the ratio. So they did have this caveat of a higher protein level for pure class 5. Their exclusion criteria, they did exclude patients with eGFRs less than or equal to 45. So overall, only included patients at a somewhat higher level of GFR than the BLISS-LN trial. You could not have malignancy within 5 years of screening, or severe cardiovascular disease, liver dysfunction, or any other conditions requiring immunosuppression or prednisone use that could alter the study. And the setup of this trial was oral voclosporin plus MMF plus prednisone versus the MMF, or mycophenolate mofetil, and prednisone. And I do want to point out, I didn't include it for the sake of time, but the prednisone regimen used in this study was a low-dose regimen. So they started out with pulse doses, so 2 pulses followed by 25 milligrams a day in a rapid taper, with the goal of getting down to 2.5 milligrams a day fairly rapidly. Their primary endpoint was a 52-week renal response. So every study has a different endpoint. So this was a 1-year endpoint. And they defined the renal response as a UPCR of less than or equal to 0.5, an eGFR of greater than or equal to 60 with no confirmed decrease from baseline eGFR of greater than or equal to 20%, and the presence of sustained low-dose steroids, so less than 10 milligram of prednisone from week 44 to 52, and no administration of rescue medication. So a little bit more stringent urine protein to creatinine ratio than the BLISS-LN trial had. And the results were that 40.8% of patients in the treatment group versus 22.5% in the control group reached the endpoint of renal response at week 52. This was significant, and about 70% in patients in the treatment group versus 51% of patients in the control group reached secondary endpoints of partial renal response at 52 weeks. And all secondary endpoints also demonstrated significance. So they had what they call a hierarchical secondary endpoint. So you had to reach one to get to the next one. And basically all of their secondary endpoints were significant. So renal response at 24 weeks, partial renal response at 24 weeks, time to urine protein to creatinine ratio of less than 0.5, and time to 50% reduction in urine protein to creatinine ratio. And this study, I will disclose, has not been published yet. This data has been released. I actually presented this at the European Renal Association, so the ERA EDTA annual meeting. Was supposed to be in Milan, but it was virtual this year, so I missed my big opportunity to go to Italy, but it was still really nice to participate in that meeting. And this was presented in June of 2020. And there will be an upcoming manuscript that's actually in revisions currently, so look out for that in the next month or two. Importantly here, as is important in both of these studies, is safety, because we are adding on immunosuppressive to an immunosuppressive regimen. And what is a great take home is the adverse events were similar in both the control and treatment group. Serious adverse events, or SAEs, were similar in both groups, including serious infection. Treatment-related serious adverse events were similar in both groups. Death was a little bit more in actually the control group than the treatment group, but there were no treatment-related adverse events leading to death, so they think this was just incidental. Disease-related adverse events were similar. Same with severe adverse events and adverse events leading to discontinuation of the study drug, whether it was voclosporin or placebo, because of course everyone was blinded. So in conclusion, have we tamed the wolf? There is no FDA-approved therapy in existence for lupus nephritis. We had our standard of care, but no FDA-approved therapy until 2020. In December of 2020, belimumab was approved as therapy for lupus nephritis, and in January of 2021, voclosporin was approved as therapy. It is important to note that both of these are add-on therapies, so they are not used by themselves. They are add-on to the current standard of care. Belimumab was studied in both MMF and urolupus cyclophosphamide, so could potentially be used in addition to either of those regimens. Voclosporin was only studied in MMF, so we only have data on adding that to an MMF-based regimen. Both studies demonstrated added efficacy when compared to standard of care. The primary endpoints were still achieved by less than half of patients in the treatment group. So I'm extremely excited. I don't want to sound pessimistic here, but we still have a long way to go, because even with these achievements, we still have half our patients not meeting the criteria they need to go into remission. So in conclusion, lupus nephritis is a severe manifestation of SLE with significant morbidity and mortality. Early diagnosis and treatment with reduction in proteinuria to less than or equal to 0.5 to 0.8 grams a day by month 12 is key to achieving long-term outcomes and keeping people off dialysis. And recently approved therapies, in addition to the current standard of care, may help more patients achieve this outcome. A large number of patients still will have inadequate response rates, and future research is really needed to identify novel therapies and better ways to identify the best therapy for individual patients. And hopefully some of the work that we're doing here at UofL will help identify these patients, and I will save that for another talk because we are out of time. Thank you so much. At this point, I would be happy to take any questions.
Outstanding. Thank you, Dr. Castor. And if anyone has a question, you can unmute your microphone and ask it, or if you want it, you can type it in the chat area and we can read it for Dr. Castor. So if anybody has any questions, go ahead and fire away. Or maybe not.
No questions? I guess I was so clear. No.
All right. Dr. Breyer, do you have anything to add or anything to?
No, I just want to thank Dawn for stepping up and giving this talk to you all, and really just this is hot off the press. So this is the new and best that we can do for lupus right now, and if I were a celebrity, I would have Dawn take care of me.
Thank you.
Thank you, Dr. Breyer, and thank you again, Dr. Castor. This is an outstanding talk. And again, if anybody has a question, you can pop in just real quick, but we're probably going to wrap up here. And again, thank you everybody for.
Yeah, I would like
have a
to
question?
say you can always email me too.
We have a question. Go ahead, Dr. Hasselbacher.
Yes, thank you for your talk. Back in 1970, when I was first involved in treating lupus, we rheumatologists had a grim humor of talking about industrial doses of steroids for nephritis and for CNS lupus. But we noticed that people began to write about aseptic necrosis of the bone in lupus at the same time. I haven't been involved in lupus for many years, but have we dissected out the effectiveness or the need for this bolus industrial dose steroids? Because in those early days, there were no trials whatsoever, and we certainly paid a high price for using high doses of steroids. To what extent are the steroids contributing to this?
Yeah, so there's some really wonderful, that's a great question. And I have a slide from another talk that I would love to email you, because steroid dosing actually has been all over the place in clinical trials in lupus nephritis. That being said, for extrarenal manifestations, since I am a nephrologist, I kind of leave it up to the specialty. So I can't state what patients should be given for, for example, neurologic manifestations of lupus. But in general, in the nephrology world and in the lupus nephritis world, we are recognizing that long-term steroid use is associated with chronic damage, which is extremely harmful long-term, and that lower doses are being utilized. So a lot of studies are using boluses of 250 milligrams of solu-medrol or 500 milligrams of solu-medrol, so a little bit lower, not the 1 gram. And the new EULAR ERA EDTA guidelines actually give some discrepancy on this bolus. So they recommend, to give it over 1 to 3 days. So some patients might only. And I will add too, what's really interesting. So the ALMS trial, I didn't go into that. That is the trial that looked at cyclophosphamide versus mycophenolate mofetil. So it really changed the way we treat lupus nephritis. Patients weren't even given a bolus of IV steroids. So, it's not universally given either. Some people go straight to oral. So the lower dose regimens long-term are being used. So aiming more, starting at like 0.5 milligram per kilogram of prednisone, and then tapering down and really getting that goal of less than 10 milligrams a day after that initial treatment period. And Some people, and actually EULAR guidelines now say really getting to less than or equal to 5 milligrams a day. You really want to get that steroid dose as low as possible, and avoid kind of long-term chronic use as well. So great question. I'm a big fan of steroid sparing, and I think a lot of our patients appreciate those approaches too. And as we have more of these kind of multi-targeted add-on therapies, one of the goals of that is reducing steroid use. Sorry, that was long-winded.
Thank you. Thank you very much. I'm glad to hear that.
Does anyone any more questions for Dr. Castor?
All right.
All right. Well, thank you again, Dr. Castor. Again, great talk, and we really appreciate it.
Thanks everybody for your attention. I appreciate